I am going to walk you through slowly some key points in understanding labor and birth. Cervical dilation and effacement. These are general measurements in order to determine or track progress. I'm using air quotes here because there are all these other subtle cues going on in your body that we might not have a metric for, but we do have a metric for cervical effacement and dilation. Depending on your provider, they might not place too much emphasis on cervical dilation and effacement. I would say this is true for most midwives. Doctors, on the other hand, sometimes they're very focused on cervical dilation and effacement because that's how they were trained. Nonetheless, let's talk about what they are. The cervix is the structure in which your baby needs to come through in order to be born into the world. Your cervix needs to thin out as well as open up. The thinning out of your cervix is called cervical effacement. Before going into labor, your cervix is thick, long, and hard to protect the baby from the outside world. Once you start showing signs of labor progressing through hormones and communication with your brain and your baby, your cervix is going to begin to thin out on its own. You need to be 100% effaced in order for you to birth your baby. Cervical dilation is how open your cervix is. Cervical dilation happens when your baby's head is pressed up against it. We need enough pressure from the baby's head in order for that cervix to begin to open or dilate. Let me show you. You may have seen this before. In early labor or before labor has even started, your cervix is closed, so you're 0 centimeters dilated. As you begin to progress through labor, your cervix is opening from 1 centimeter to 10 centimeters. I am not going to teach this the way that childbirth textbooks teach it in medical school, because what I want to stress is that there is no telling how fast someone can dilate or efface when they feel relaxed. If someone is stressed or anxious, the progression through dilation and effacement can be very slow. Early labor is considered from 0 centimeters to roughly 6 centimeters. Just recently, the American College of Obstetrics and Gynecology changed the criteria of what they consider active labor from 4 centimeters to 6 centimeters. The reason they did that is because they're trying to help patients arrive to the hospital later in active labor so that labor doesn't stop or stall or slow down as it often does when someone arrives to the hospital too soon. You can dilate before you efface, or you can efface before you dilate. It doesn't matter, but you do need to be 100% effaced and 10 centimeters dilated. And until you do so, you are still in active labor. I do have a story to tell you, and that is about a client I had recently. We arrived to the hospital and she was 4.5 centimeters. She had labored at home for a really long time, and when we got there, we were kind of surprised that she was still only 4.5 centimeters. Because she felt so relaxed, she went from 4.5 centimeters to 10 centimeters in under 2 hours. And she was a first-time mom. I want to stress not to fixate too much on these numbers. Try not to get too discouraged if you get a vaginal exam and they check you and you're only 2 centimeters. The more relaxed you are, the more likely that you will make change to your cervix. There are many, many signs of labor starting, but there are some really important ones I'd like to highlight. The first one being the mucus plug. What a terrible term. I don't like the term, so I have renamed it as baby gel after my amazing 75-year-old mentor who also taught it as baby gel. Essentially, it is this jelly-like lining along the cervix that protects the baby from the outside world. And your hormones, as you prepare for labor, they can dislodge the mucus plug or the baby gel, and you can see it when you toilet. It's important for you to look at the color. If it's clear, if it's pink, or a little bit of red, which means that there is blood present, it is okay. You can wait for another sign of labor to start. If the baby gel is green or brown, it could indicate that the baby had his or her first bowel movement, which, if you remember, the first bowel movement is called meconium. If we see green or brown in early labor, you are going to want to call your provider. Most of the time, providers will suggest that a client or patient go to the hospital maybe earlier than they had anticipated or wanted to go, because we want to make sure that the baby is still healthy and everything is normal. And sometimes when the baby has a bowel movement in early labor, we want to have more monitoring. And the reason for that is because at the time of delivery, we do not want the baby to inhale or ingest meconium. We don't want that going into your baby's lungs. Just because there's meconium present doesn't inherently mean your baby is going to ingest the fluid. You may or may not notice your mucus plug or your baby gel coming out. It can come out in one big blob. It can come out in stringy bits. The other important thing to note is that if you don't go into labor within usually 48 hours, it will regenerate itself to protect your baby, which is kind of amazing. If you get a vaginal exam, let's say at 38 weeks, you're nowhere near being in labor, you have no signs of labor starting yet, but your provider wants to check your cervix and do a vaginal exam, sometimes they can disrupt the membranes or disrupt that baby gel and it can come out. That doesn't mean you're going into labor. But if it comes out on its own without anyone up there fiddling around, then you could potentially be going into labor. You may also notice your mucus plug or your baby gel come out if you are sexually intimate. This is a good sign because your body is releasing the hormone oxytocin, which is the love hormone. We only produce it when we feel relaxed and we feel good and we feel safe. If being intimate with your partner allows you to feel those things, it's worth trying in order to get you to go into labor naturally. Another sign of labor starting is bloody show or birth show. You may or may not know this, but there is blood involved in childbirth. It is a healthy part of labor. But it's also important to know how much blood is too much blood. If you're using the toilet and you can't see the bottom of the toilet, that might be too much. I highly recommend calling your provider or going to the hospital or having your midwife come over immediately. It might be a little too much. Or if you put a maxi pad on and you soak through it in 30 minutes or less, that's kind of a lot of blood. But if it's like a period or a little less than a period and it's sporadic or there's spotting, that is totally healthy, normal, and fine. Let's talk about the next sign of labor starting, your water breaking. And the water breaking can happen in a couple different ways. It could be a trickle of fluid coming out, or it could be a gush of fluid. It's important to know the difference because if it's just a trickle of fluid, you might think that you peed yourself, but you're gonna know that it's not pee. It's got a strong, astringent smell. I promise you, you're gonna know it's not urine. And when in doubt, you could put a pad or a liner on so you can track the fluid and the color and the consistency to know if you need to call your provider. If your water breaks with a gush, it usually means the water has broken low to your cervix. What that means is there's no protective barrier between your baby's head and your cervix. Now the baby's head is completely pressed down on the cervix. So usually when the water breaks with a gush, labor might kind of move a little bit more quickly. When your water has broken with a trickle, that usually means your bag of water has broken high in your uterus. So it's a high leak, maybe up near your rib cage, and it's just slowly trickling out. Whether it's a gush or a trickle, it's very important to stay hydrated. Again, with your water breaking, you want to be mindful. What color is it? If it's clear, pink, or red, great. Wait for another sign of labor to start. If your water fluid is green or brown, call your provider. I will suggest, if you are doing an out-of-hospital birth and you think you have seen green or brown, absolutely call your midwife and make sure you review the protocol with them. A sure tell sign that labor has started are contractions. Your uterus, which is a muscle and an organ, that needs to tighten and release. It is the tightening, that is the contraction. That is communicating to your baby, it's time to come down, it's time to be born. Contractions need to be long and strong in order to create change on the cervix. So if you are experiencing contractions, but they're short, or they're inconsistent, or they're sporadic, you don't need to time them or keep track of them, just wait it out a little bit. But as soon as your contractions are strong and follow a pattern and are consistent for at least several hours, and the contractions are at least 1 minute long, then you can start timing them. Now you're sort of inching your way into more active labor. There are timers that can send your birth support person a live feed of your contractions so that they can kind of watch and check in with you and see how you're doing. Vaginal exams. We talked about this a little bit earlier, but it's worth bringing up again. Obstetricians are going to do more frequent vaginal exams because they're more reliant on the cervix showing change than a midwife. If you're having a hospital birth, there are only 2 times that it is considered necessary to get a vaginal exam. The first would be upon being admitted into the hospital. The reason for that is because if you're not in labor yet and you're 0 centimeters dilated, you probably shouldn't be admitted. Well, why is that? Because if you choose to be admitted and you're not in labor yet, and then for whatever reason, because you changed your environment, oftentimes contractions might slow down or fizzle out, then you might need to rely on medical intervention in order to progress your labor. For some people, they're okay with that. But if you're someone that would like the least amount of medical interventions, I recommend getting that vaginal exam. You can't really check your own cervix, although I don't know, the internet is a wild place. If you don't have a doula, you need to keep track of your contractions, have your partner time them so that you can focus on breathing and on your body. When you start noticing that contractions are at least 1 minute long and they're coming consistently for at least several hours, you're going to start to feel different sensations in your body that are indicating that it's time to go to the hospital. One of them being that you feel like you need to have a bowel movement. And as baby descends into the pelvis, your baby's head is angled towards your rectum, so it really does feel like you want to poop out a bowling ball. You won't, it's your baby's head. But that's what the sensation is like, and often you start to feel it during contractions and then it'll go away in between contractions. Eventually you'll feel consistent rectal pressure with or without contractions. And generally I recommend clients go to the hospital when they start to feel that rectal pressure. If you're someone that runs anxious, it's not the end of the world if you show up to the hospital too soon. You're gonna be okay. But for clients that would like to do it with the least amount of medical intervention, you might want to labor at home as long as possible and maybe work with a doula. A doula doesn't measure your cervix, and they don't need to, because they're paying attention to all of the other signs to see if you're making progress. In fact, I recommend work with a doula despite how you plan to give birth. It's just helpful. If you're having a hospital birth, you get a vaginal exam upon being admitted. The other time that it is necessary to get a vaginal exam is when you're ready to birth your baby. When you feel an urge to push, when you are 10 centimeters and 100% effaced, we want to make sure that there's no more cervix left before you begin pushing. If there's still cervix left and you have begun pushing, you could have some pretty severe tearing or trauma to your cervix. It's different when you're having an out-of-hospital birth. A lot of midwives don't need to check you as frequently because, again, they're more sensitive and they're more in tune with the other subtle clues of progress that I've talked about. So let's role play some common scenarios. Let's say it's the middle of the night, you're asleep, your partner is asleep, and you wake up because you're feeling some cramps and you feel this pop of fluid, and you go to use the restroom and you feel like all of this warm fluid going down the side of your leg, and you go to the bathroom. What can you do? The first thing you can do is look at the color. Is it clear, pink, or red? Great. Go back to bed. Go back to bed, rest some more. Maybe your body just needs a little bit more time for those contractions to get strong. If it's green or brown, you're going to want to call your midwife or your doula and help them figure out, is it time to go to the hospital or is it time to call the midwife? You can send photos to your doula. I've seen many amniotic fluid photos. Now, let's say it's the middle of the day and you use the restroom and you notice some discharge and it's got this jelly-like consistency and maybe it's a little tinged pink. You have no contractions, but you're wondering, maybe this is my baby gel. What can you do? Well, first of all, it's the middle of the day, so maybe you go home and you take a nap. Or maybe you are out running errands and you think, oh, well, it's still early, so I'm just going to continue to run my errands. Both of those options are totally fine, but I don't want you to freak out and think, oh my gosh, labor's happening right now. I need to get home and pack my bag and go to the hospital immediately. There's a lot more time than you think. And by the way, why do you think labor often occurs at night? Because the mom is the most relaxed. So here's another scenario for you. It's the middle of the day, you feel contractions, they're getting pretty intense, they're 1 minute long, they're relatively consistent, but no other signs of labor. What can you do? Well, if you're out and about, I would certainly go home. I would definitely try and take a nap, try and rest, just reclined in bed or on the couch. That is conserving your energy. And the same is true if labor starts in the middle of the night with strong contractions, even if you can't sleep. As long as you're resting, maybe you put on a podcast, maybe you watch your favorite show that relaxes you and is sort of mindless. It will be clear that labor is really advancing when you cannot rest anymore laying down. So if you've been resting and laying down and you just cannot get comfortable no matter how hard you try, even in between contractions, it's really uncomfortable, okay, then we're starting to inch towards active labor. There's a really helpful mantra I suggest to my clients, and that is to stay in denial as long as you can. Why? Because if you are in denial, you're not anxious, you're more neutral. It allows things to happen in their own way, in its own time. Now, whether you have an in-hospital birth or an out-of-hospital birth, your provider is going to be checking your baby's heart rate, either by using a Doppler or wearing monitors. They are making sure that your baby is coping with feeling contractions and getting squeezed by your uterus. I know we've talked a lot about the different signs and the different metrics used in the hospital and outside of the hospital to track progress, but I'd like to invite you to not get too hung up on these different metrics. Sometimes metrics give this false sense of linear progress. Labor is far more complex than that. Our bodies are far more complex than that. Our babies are more complex than that. We're not a computer, so things ebb and flow. In review, in early labor, if you are feeling contractions, they might be inconsistent. They might not all be 1 minute long yet. Maybe you're noticing a little bit of blood or a little bit of baby gel. These are all early signs that we're still waiting for things to become more consistent. If we are equating that with your cervix and a metric, that would be from 0 to roughly 5 or 6 centimeters. Once you're at 5 or 6 centimeters, You're now considered in active labor. You don't necessarily need to know if you're 5 or 6 centimeters because you're going to feel strong, consistent, 1-minute long contractions. You might also see some bloody show. You might also see your mucus plug. Your water might break. All of these signs start stacking up, and that's how you know you're in active labor. These signs don't all happen in the same order, but all of those things will happen at some point in labor, whether you notice them or not. What you will notice are those contractions. To illustrate how complex our bodies are, someone could show up to the hospital at 7 centimeters and feel an urge to push, and all of these other signs are all stacking up. However, they could be at 7 centimeters for 4 hours long, 6 hours long. And it might be due to how the baby is positioned in utero. So as much as your body needs to make progress, we also need to see that the baby is responding well and making progress as well with engaging and moving down through the pelvis. This is a model of your pelvis, and if you can imagine, your baby is going to have to move through your pelvis in order to be born vaginally. And when we talk about cervical effacement and dilation, there's one other thing that we need to factor into the equation, and that is, where is your baby's head in relation to your pelvis? If we were to cut this pelvis in half, we would call that midline of the pelvis, which is considered 0 station. So when your baby's head is officially engaged in the pelvis, your baby's head is sitting at 0 station, which is reflective to the midline of the pelvis in relation to your spine. Now, if your baby is not quite engaged yet, there would be a different number. There's -1, -2, and -3, which is floating above the midline of your pelvis. Once your baby passes the midline of the pelvis, there is +1, +2, +3 station, and that refers to where your baby's head. So if this is your baby's head and this is your pelvis, so if there's a positive number, it means your baby is below the midline of the pelvis. And if there's a negative number, it means your baby is still floating above the midline of the pelvis. Your provider can check not only how dilated and effaced you are, but also where your baby's head is and what station your baby's head is at. If you consent to getting a vaginal exam, you can ask your doctor or midwife, how dilated am I? How effaced am I? And where is my baby in relation to my pelvis? What station is the baby at? Now, if your baby is floating above the midline of the pelvis at -1, -2, -3, your baby is still quite high. So if you wait until that baby moves down to maybe +2, +3, you won't have to push for as long or as hard. In a hospital setting, there is a pushing time limit. In my area, it's 4 hours. If you've started pushing long before you feel an urge to push, or if your baby is still very high in your pelvis, you're going to be wasting precious energy pushing. I strongly urge you to wait to push until your baby has descended to a lower station and or you're feeling a strong urge to push. Every provider has a different preference on their client or patient getting certain tests and screenings while pregnant. The NIPT test, or non-invasive prenatal testing, is screening to see if the baby is inheriting any rare genetic disease. But just know, this screening is not 100% accurate. Not all of my clients get NIPT screening, but I would say the majority of them do. Another test screens for gestational diabetes. If you have a doctor, they might prefer that you take a specific gestational diabetes drink, but a lot of doctors are open to alternative ways to test your glucose levels. There's something called a fresh test that is often approved by obstetricians. But there's a lot of hesitancy from my clients to take the traditional sugary orange drink that is given to them by their doctor because of the added preservatives, the unnatural dyes found in that drink. If you have a midwife, sometimes they'll just give you a recipe. You make the recipe and then they test your glucose level. It's a little bit more relaxed. And then there are some clients that choose not to be tested at all, and that is certainly an option for some people. At the end of pregnancy, many providers screen for something called group beta strep. I encourage you to research it. The United States is one of few countries that even screens for it. It's kind of interesting that some of these screenings are only done in the United States. Your baby can be in so many different positions while in utero. Your baby can be head down. Your baby can be breech, which is head up. There's different kinds of breech. Your baby could be sideways or transverse in utero. I've included at the end of this module some resources where you can look at the different positions baby can be in. If your baby is breech, there might be some additional things that you can think about in order to encourage the baby to turn head down. The reason we prefer a baby to be head down is because that is how you are most likely to have a successful vaginal delivery. There may be a few providers left that feel comfortable delivering a breech baby vaginally, but most of the United States providers do not feel comfortable. Another thing to note about breech babies is there is an additional option available to you, which is called an ECV, or an external version, and it has a success rate of about 50% of the time. Some babies can flip at the last minute on their own. Sometimes that ECV works, but I think some people decide not to do it because it's uncomfortable, and sometimes the doctor prefers that the patient be anesthetized or get an epidural in order to attempt to turn the baby because it's uncomfortable. They can try seeing a chiropractor or doing acupuncture or seeing someone like a pelvic floor specialist to help encourage the baby to turn. A skilled pelvic floor specialist can help release any fascial tissue that can help turn the baby as well. Pushing is such a hot topic when we talk about giving birth. Some childbirth educators tell you, don't push, you're going to know when to push, and if your body knows what it's doing, you don't need to push your baby out. But then a lot of people that give birth in the hospital, they are told by their doctor or by the nurses that they need to push their baby out. And even if you're having a home birth or a birth center birth, oftentimes the midwife will instruct the client to push. So it's very confusing. I think it's important to be open and flexible to what your body is saying and doing, and being able to recognize, oh, maybe I feel an urge to push. There's this phenomenon called the fetal ejection reflex, and someone may or may not feel it. It feels like your body is trying to help you push your baby out, similar to a bowel movement. If you know you need to go to the bathroom, do you need to go sit on the toilet hours before you need to go and strain and force it out? No, we don't do that. I have had some clients not feel an urge to push, even though the baby is super low, and that's okay too. Sometimes people start pushing because the baby is looking tired and we need to get that baby out sooner rather than later. We would ideally like your baby to be born healthy, and we would like mom to be healthy, and we would like mom to feel calm and confident and supported. So there's different philosophies of pushing. There's forced directed pushing, which you will often see in a hospital setting, but I have seen it at home births and at birth center births too. There's this concept of breathing your baby down. So not active like straining, but more breathing baby down. I think that is a beautiful thing to try, but often with a first-time mom, they might need a little bit more help or a little more oomph behind the pushing. Sometimes everything in your body is telling you to push, but maybe there's still some cervix left. If you don't yield and slow down with pushing and you just push straight through because you feel that urge, then there might be some tearing in that situation. Also, when you're pushing, you might see your baby's heart rate decelerate a little bit, and that is pretty typical as baby starts to emerge in the birth canal. If you see your baby's heart rate decelerating and you're not pushing yet, it could mean that baby is in an unfavorable position, or perhaps the baby is compressing their umbilical cord, which temporarily cuts off oxygen. When we see your baby's heart rate decelerate, we want to see that the baby recovers in between contractions. So if there's a contraction and we see on the monitor that the heart rate kind of dips during the contraction, okay. But as soon as the contraction is over, we want to make sure that that heart rate kind of goes back up to its baseline. If baby's heart rate does not recover, then you might see some nurses come in the room, or your doctor might show up just to help mitigate the situation and see if they can get you in a better position for you and your baby. What I mean by a better position is your doctor or the nurse might move you on your side. Sometimes when a mom is laying on her side in labor, it helps the baby's heart rate to recover. Tearing. Everyone is afraid of tearing, but not everyone tears. Perineal massage is essentially manually stretching the perineum, that tissue, that skin, so that when baby starts to stretch the perineum, there's less of a chance of the perineum tearing. I always tell my clients, you can try perineal massage, but do it from a place of self-inquiry and discovery, not because it's going to give you the outcome of no tearing, because honestly, we don't have control over that. Your energy will be best utilized through breathing, which will help send oxygen to those tissues. And there are other factors that contribute to whether or not you tear, like baby's position and how hard are you pushing, and what is your position? How are you choosing to birth your baby? Some of the rhetoric out there says that you should not birth your baby on your back. If you are giving birth on your back and you have low back pain, you're essentially giving yourself counter pressure, which can be very supportive. So I don't like these one-size-fits-all statements about don't birth on your back or you need to use gravity to birth your baby. That's true for some people and not true for other people. If you're giving birth in the hospital, doctors tend to prefer that you push in the bed. So if you have strong opinions about that, you want to have a conversation with your provider and say, hey, I might not want to push on the bed. How do you feel about that? Some providers are a little resistant to that, again, because of this question of liability. Maybe they're not used to assisting a delivery off the bed, whereas a midwife is going to be a lot more neutral. You want to give birth on the floor? Fine. You want to give birth on the toilet? Fine. You want to give birth in the tub? Okay. Don't wait until the last second to tell your doctor if you have strong opinions about how you want to push or birth your baby. Sometimes when you're working with gravity, whether you're squatting, on hands and knees, these positions, you're using gravity to help you push the baby down and out. Sometimes it makes it difficult to ease off the pressure. So there's a thought that if you work against gravity, whether you are on your back or on your side, that baby can emerge a little bit more slowly, so there's less of a chance of tearing. I wouldn't say this is universally true. Again, it goes back to what is your body saying? How can you take your time? Are you listening to your provider if you need to slow down in order to accommodate baby's descent? There are options you get to make surrounding your umbilical cord. Something called delayed cord clamping is considered best practice by both midwives and doctors alike. Essentially, that means that they leave the umbilical cord attached to your baby and the placenta after the baby is born in order for your baby to receive the blood that is still in the cord and the placenta at delivery. Approximately 1/3 of your baby's blood is still inside the placenta at the time of delivery. So that is the reason why it's generally recommended to delay cord clamping or cord cutting. We know when the baby has received most of the blood because you'll see that that cord turns white and it stops pulsating. You can literally see it pulsing if there's still blood in it. Also, that cord will be this beautiful purple color if there's still blood inside. There are exceptions to this rule. For example, if baby comes out and baby is not looking well, or if baby needs help with breathing or any sort of assistance, then they are going to cut the cord quickly, even if your preference is to have delayed cord clamping. Why? Because we need to make sure that the baby is able to breathe, and sometimes they will cut the cord quickly in order to bring the baby over to a warming station, or your midwife needs to check the baby. They need to disconnect the baby from the umbilical cord. Then there's cord blood banking. Doctors can make about $500 for every patient they refer to cord blood bank. Cord blood banking is to store your baby's cord blood in case you need access to your baby's blood later on in life. Usually it's used for a subsequent child or a sibling of that child in case that child is sick. There are stem cells in the cord blood that can be used. But if I'm being honest with you, these cord blood banking facilities are privately owned and operated. They have very little transparency around how they store your baby's cord blood, how they may utilize or collect data on your baby's cord blood. I've had some clients do cord blood banking and they tell me it's very expensive, and out of all the hundreds of births I've attended, I have never heard of a client needing access to their baby's cord blood. Your placenta has an estimated street value of $50,000. Why is that? Because similar to your baby's cord blood, there are stem cells in there that are very valuable to medical research, cosmetic companies. If you decide to take it home with you and encapsulate it and then consume the encapsulations, midwives have anecdotal evidence that consuming your placenta can prevent postpartum mood disorders, especially in women that have anxiety or depression prior to becoming pregnant. But it is anecdotal evidence, and you just are not going to find medical research that supports consuming a human placenta because it doesn't benefit pharmaceutical companies. When we look at it from an evolutionary standpoint, mammals in the wild eat the placenta in order to avoid predators coming and trying to kill their offspring. But whether or not there's nutritional value in consuming the placenta is still up for debate.